Today, we are going to start with the pathology of the brain. Pathology of the brain tend to be super important. Why? Because as a physician, it doesn't matter, are you planning to become a GP or are you planning to become a neurosurgeon? All of you guys will face these pathologies. Maybe in a practice, like as a GP, or it can be in your specialty somewhere. So yeah, all of you will see it somewhere. So let's take a look at them. The first page is a little bit painful because it just speaks about general structure that are located in the brain and what is going to happen when you destroy them or when you have some form of affection of them. But after we finish the first page, it becomes a smooth sail because it starts speaking about general pathologies which are much more easier to deal with. So let's start with the first page. So the frontal lobe. Our frontal lobe is responsible for our behavior, right? So the person behavior can be messed up if he has destruction of his frontal lobe. So he will be disinhibited. Guys, when you drink alcohol, you do stupid stuff that you are not supposed to do. Why is that? Because your frontal lobe is inhibited. You know, who is more, not smart, but more disciplined, a 15-year-old or a 25-year-old? Who's more disciplined? 25-year-old. You know that, but you don't know why. The reason that a 25-year-old is more disciplined than a 15-year-old is that the frontal lobe in a 25-year-old is much more developed, while in a 15-year-old is not yet developed. Our brain keeps developing until the age of 21. That's why before that, we are pretty much stupid. We are disinhibited. We don't have the wise brain regulation over our brain. But until the age 21, after that, the brain frontal lobe start becoming more developed, which will prevent you from doing stupid stuff that you should not do. Okay? So yeah, that's we call wisdom. This inhibition, so frontal lobe can lead to the following damage, basically. So this inhibition and deficits in concentration is responsible for orientation and judgment and may have re-emergence of primitive reflexes if you have destruction of it. What are primitive reflexes? Primitive reflexes are the reflexes we spoke about yesterday: the Moro, Rotting, Balmer, Plantar, and Galant reflex. All of these ones. But for the sake of the USMLE, the most important one between all of these are the Babinski sign, which is when you just touch the foot from down, right? The patient is going to dorsiflex his big toe. That's the most important one. And remember, it's a sign of upper motor neuron lesion. The frontal eye field, however, is a little bit different. So for the frontal eye field, it goes something like this. It's a destructive lesion, can affect it. Of course, the frontal eye field is somewhere right. It's in the frontal lobe, it should be. And I'm just trying to, oops. Oh. Okay. One second. Okay, sorry everyone. I accidentally exited the thing. Wanted to exit something, exited the other tab. Okay. So, I can't blame it on my brain. It's not me who did it. So, yep, my proprioception was not working. I did not know where was my finger. So the frontal eye field is located basically in the frontal lobe. So if I draw a brain like this, it should be somewhere right here. Of course, this is the central fissure. This is the lateral fissure. The frontal eye field should be exactly right here. A destructive region, for example, in case of MCA stroke, will eyes look towards the brain lesion. So if it was on the right side, you will look to the right side. If it was on the left side, it will be on the left side. Does anybody know what is more common to get infarcted? Is it the right MCA or the left MCA? Yes, it's the left MCA because, as I told you, the vessel there is much more smaller, okay? So I look towards the brain lesion, away from the side of hemiplegia. Remember, hemiplegia is basically contralateral. So you basically look at your vein, okay? Look at your vein. So you look towards the lesion with your eyes. So why the hemiplegia is on the other side? Because it dissociates to the other side, basically, because of the corticospinal tract. Remember, corticospinal tract dissociate, which means it passes over to the other side at the pyramid of the spinal cord, of the medulla oblongata. The next thing is something known as the pyramidian pontine reticular formation. BPRF, also known as that. Please write the abbreviation because they mention it everywhere like this. So this pyramidian pontine reticular formation, also known as reticular formation, a lesion of it will make you look away from the brain lesion towards the hemiplegia. Why? Because it's in the brain stem, not in the brain himself. Please make a little note. Okay, I'm kidding. Make a huge note regarding the reticular formation. Reticular formation is the structure that keeps us awake. It's the structure that keeps us awake. So if you have destruction of the reticular formation, you will be in a... So reticular formation keeps you up. If you destroy it, you will go to sleep. Exactly. Coma. Yes. So that's important. The next thing is, and actually when we go to sleep, guys, our circadian cycle work to turn off the reticular formation. That's why we sleep. Medial longitudinal fasciculus goes something like this. It's a white matter structure, which means it's composed of axons, and this is a connection between multiple nuclei. Don't worry about it a lot, because we will discuss this tract in details when we discuss multiple sclerosis. Basically, it's a tract that helps synchronize the movement of your eye, okay? I mean, when I look to the left with my right eye, my left eye should also look to the left. But this right eye is doing what? Abduction, right? But the left eye is doing adduction, right? This system is synchronized. So we are connecting cranial nerve number 6, which does the abduction, with the cranial nerve number 3, which do the adduction, correct? So there should be some form of connection, don't you think? That connection we call medial longitudinal fasciculus. I will not go into further details because this is related to multiple sclerosis, but this is a general idea. So it's an intranuclear ophthalmoplegia, which... Oops, can you hear me, guys? Can you hear me now? Okay, so I'm going to say a sentence. If it stays the same problem, please let me know. Frontal eye field, destructive lesion. The eye will look away towards the brain lesion. Can you hear me? Oops, okay. What about now? Can you hear me? Excellent, good. So let's see. So now we are going to speak about medial longitudinal fasciculus. Remember, it's just a connection between the nucleus of the third cranial nerve and sixth cranial nerve, right? This is the longitudinal fasciculus. It's white matter. That means it's made up of axons. Yes, Intranuclear ophthalmoplegia, which means problem with the movement of the eye. So impaired adduction of the ipsilateral eye. So you cannot adduct the eye on the same side of the lesion. Nystagmus on the contralateral eye with abduction. Let's try to understand what does that even mean. We will speak a little bit more about intranuclear ophthalmoplegia, but I just want you to know the general idea here. So the idea is like this. So I told you, it's just a connection. So medial longitudinal fasciculus is just a connection between two structures. The nucleus of the third cranial nerve and the nucleus of the sixth cranial nerve. So basically, the sixth cranial nerve, if you want to look to the right, he will look to the right. But in the same time, he will be like, dude, third cranial nerve, you should adduct to look to the right. Okay, if this is destroyed, okay, this is destroyed. Now you try to look to the right. The right eye will look to the right, but can the left eye look to the right if the MLF is destroyed? Well, again, so this is the sixth cranial nerve. It tells the lateral rectus to look to the right, look to this side. And in the same time, it synchronizes the movement of the left eye to also look to the right by telling the medial rectus to contract. The medial rectus is controlled by the third cranial nerve. So he needs the MLF to do that. Medial longitudinal fasciculus. So if this guy is destroyed, the right eye will still be able to look to the right, no problem. But can the left eye do it? What do you think? Can the left eye do it? Looking to the right, if the MLF was destroyed? The answer is, it cannot. It cannot do it spontaneously. It cannot. Okay, so the next thing is, it occurs in multiple sclerosis because of oligodendrocyte destruction. Good. The next thing goes something like that. Dominant parietal cortex. Oh, parietal cortex. Now we are speaking. So yeah, you do have multiple lobes in your brain. And the main ones, of course we have the insula, but the main ones are the frontal, parietal, occipital, and temporal. So when we speak about the temporal lobe, you have two of them. You have the right one and you have the left one. You should understand that you do have a dominant and a non-dominant one. In most human beings, which one is dominant? Is it the left one or is it the right one? In most human beings. Well, in most human beings, in most of them, it is the left one, okay? In most human beings, the left parietal lobe is the dominant one. In general, I draw just, this is the left hemisphere and this is the right hemisphere of your brain. Each one of them has its responsibility. This is quite cool actually. So if we speak about left and right hemisphere, the left hemisphere is responsible for your language. What do you speak about? The numbers, the calculation, stuff like that. So yeah, it's basically, okay, I like this image, exactly. So you have your left and right hemisphere. The left one is more the, facts, stuff that you actually can calculate. For example, the mitochondria does this, the mitochondria does that. Today, after the class, I have to rest for a little bit. After that, I have to start studying for my step 3. So planning, okay? I'm making order to stuff. 2 times 2 is 4. Mathematics, that's help us with that. Focus on fact. For example, yes, if you study all of the material and go to the exam, you will pass. This is facts. And logic. So this is everything that associated with facts and logic and stuff that actually real. But when you imagine stuff, This is what the one is working. Oh yeah, one day we'll go to the US, become great doctor, and yeah, become an astronaut, and yeah, and I have this work of art that I want to sell. Yeah, so that work of art that you have done from your imagination. Your imagination is located at the right side of your brain, not the left side of your brain. And you need to understand it's really active in people who like the science fiction stuff. Okay, so it's the imagination part of your brain. Is it important? The answer is absolutely. This is the thing that make you creative, guys. The left one is amazing. He's the one that gets you a job. But the right one is the one that makes you enjoy your job. Okay, so that's in general. In general, also the left lobe is the one that is dominant. Okay, so dominant parietal cortex, which is the left one. In this patient, they will have agraphia, an ability to write, acalculia, an ability to calculate. Remember, the left one was responsible for numbers. Finger agnosia, which is an ability to, like, point stuff. And left to right disorientation. You ask it's actually quite interesting. You tell him, so which one is, can you please hold the right pen? We'll be looking at it. What the hell? Which one is right? He does not have differentiation between right to left. Actually, quite interesting. We call that Gerstmann syndrome. Gerstmann syndrome, it's when you have all of these symptoms together at the same time. That's Gerstmann syndrome. So you have basically the agraphia, acalculia, and all of the other ones. And most likely it's on the left side problem. Okay, so you can see acalculia, agraphia, left to right disorientation, and finger agnosia. Okay. So remember, it's the left brain in this case. Mostly, of course, mostly. Guys, by the way, left-handed people, the dominant lobe for them is the right lobe. Right-handed people, the dominant brain for them is the left one. So somebody now will ask me, what about the people who can use their both hands? That's interesting. They don't have a dominant lobe. So even if they have a stroke of one of them, the other one will compensate for that. Non-dominant parietal lobe, which is most likely to the right, they will have agonesia of the whole contralateral side of the word. What does that mean? It's hemi-neglect syndrome. When you tell the patient to shave his head, he's going to shave half of his head. When you give him a paper, tell him to draw a clock with numbers on it, he will be like, okay, so it's 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. You are like, what about this side? He's like, which side? I cannot. There is no side here. They basically can't see it, but they don't understand its presence. When you tell them to shave, they will shave only half of their face. And it's happening because of an infarction of the parietal lobe. Oh yeah, this guy. See? They told him to shave his face. Only half of his face. See the clock? Just write us the number on the clock. See, from 12 until 12. But all on the same side. Yep. Basically, they cannot appreciate the presence of a left side. For them, it does not exist. Okay. So, oh yeah. So they just imagine something like this. This is pretty dangerous because if their left hand gets cut, they cannot appreciate that this happened, you know? They just don't understand its presence. Okay. Good. The more interesting thing, if you tell them, for example, can you please draw me a flower? So he will be like, okay. He wants me to draw him a flower. So this is a flower. I'm like, wait, what about the rest of it? He's like, what rest of it? There is nothing as rest of it. Okay, so that's hemi-neglect syndrome. The hippocampus. Okay, I told you about the hippocampus before. What is hippocampus responsible for? formation of a new memories. Absolutely correct. So if you destroy the patient hippocampus, can he remember his past? Can he make new memories? Nope, he cannot. Okay, good. So they write, hippocampus, anterograde amnesia, and ability to make new memories. Just for the sake of completeness, I would like you to know where does the hippocampus exist. Actually, not for the sake of completeness. They do ask about where it is. They like to show you a cross-section of the brain. Trying to find a cross-section. Okay. So this is your hippocampus. Basically, this is your temporal lobe, and this is your hippocampus, and the amygdala is a little bit above it. Okay. So they write, an ability to make new memories, andrograde amnesia. Basal ganglia may result in a tremor at rest, chorea, and athetosis. Chorea is an improper movement of the whole limb, okay? Athetosis is a snake-like movement of the hand. Let me just show you a picture of chorea. So chorea, if you remember, there was a disease we spoke about in cardiology that can lead to chorea as well. Does anybody remember which disease in cardiology leads to chorea? See? Rheumatic fever, absolutely. Okay, so that's chorea. Now hemiballismos. The whole arm. See, she's trying to resist it, but she cannot. The whole thing is moving. Oh yeah. This is subthalamic lesion, subthalamic nucleus lesion. Okay, the next one is athetosis. Athetosis is a snake-like movement of your fingers. Oh yeah. Okay, so I have an idea about each of them. So, basal ganglia destruction can lead to this stuff. It can be in Parkinson disease. We have the tremor basically. It can be in Huntington disease, which has the chorea and athetosis. It can be in Wilson disease, which also have the tremor. Subthalamic nuclear destruction can lead to contralateral hemiballismos, which you have just seen. Mammillary body affection can be destroyed in Wernicke-Korsakoff syndrome. I hope you remember about that. Can you tell me what was the only symptoms that help you to differentiate Wernicke-Korsakoff, Wernicke syndrome from Korsakoff? Wernicke-Korsakoff basically. There was one symptoms that help you to differentiate between the two. What was it? It was the confabulation. Confabulation is making up stuff. For example, if you, if you ask the patient something and he does not remember, he will make up something. If you tell him what you have done yesterday, and he was yesterday at the hospital, but he does not remember, he is confused, he's, junkie. He will tell you, well, yesterday I was on a date with a beautiful lady in the Caribbeans. You'll be like, right. And you will ask him, what did you eat there? He will be like, we ate sushi. And after that, we walked near the sea. And he will be speaking with details, All of that is confabulation. Because all yesterday, he was at the hospital. So Wernicke-Korsakoff syndrome, they will have confusion, ataxia, and nystagmus, which is vibratory movement of the pupils of the eye. And ophthalmoplegia, which is basically problem in the movement of the eyes muscle. So they will have memory loss, both antro and retrograde. And the most important symptoms for the Korsakoff is the confabulation and the personality changes. Most likely it occurs with people who have thiamine deficiency due to alcoholism. So Wernicke problems come in a can, a beer can, and other condition associated with thiamine deficiency. Amygdala is responsible for our emotion slash behavior. So person with destruction of his amygdala, two-sided, well, let me say stimulation of it, will lead to something called the Clever-Bowsy syndrome, especially in case of encephalitis. So that's why I'm saying stimulated. HSV-1 encephalitis. In that disease, I just want to show you an MRI first of all of it, HSV-1 encephalitis. It will only affect the temporal lobe, by the way. The white stuff is inflammation. So you can see it's only affecting the temporal lobe. Of course, this is the temporal lobe, guys. This is the temporal lobe. This is the lateral sulcus. This is the lateral sulcus. Yeah. So if it is inflamed from both sides, it will lead to disinhibition of the patient, also known as a Clever-Bowsy syndrome. This inhibited behavior, the patient will have hyperphagia, hypersexuality, and hyperorality. Okay? What do I mean by hyperphagia? He will be hungry. He will eat anything around him. Hypersexuality. Guys, I'm not saying hypersexuality, he will go over ladies. He will go over anything, including objects. I was reading a story about some guy making love to a car, and he was caught and taken to the hospital, making love to someone else's car, and yeah. So, and hyperorality. They will be having this improper tongue movement all over their face. Basically the creepiest things you can imagine in front of you. So, dorsal midbrain. The dorsal midbrain can be destroyed, especially, yes, stroke hydrocephalus is correct, but the most commonly on the exam, it will be a benilioma. A benilioma, a cancer of the pineal gland, is going to grow and is going to compress the posterior. See, this is the pineal gland, okay? So when the pineal gland becomes big, it's going to compress this guy, which is the midbrain. Okay, do you remember which cranial nerve comes out posteriorly from the midbrain? Okay, let me repeat the cranial nerves for you. So 12, 11, 10, and 9, all of this coming from the medulla. Next, we have 8, 7, 6, and 5 comes out from the bones. 4 and 3 comes from the midbrain. See, the number is just going down. 1 and 2 comes from the hemisphere directly. Okay, how to know if it is medial or lateral? Medial divide on 12. Well, basically the 12 divides on it, which are cranial nerve number 12 and 6 and 4 and 3. All of these originate from the brain medially. The midbrain is special because it's the only one that has a nerve that originates posteriorly, posterior origin nerve, which is cranial nerve number 4, also known as the trochlear nerve. So, okay, so basically it can compress this cranial nerve, which is the trochlear nerve, because it comes posteriorly, right? So, let's see the symptoms here. A benilioma, they right? It can lead to something called Bernoulli syndrome, which is a destruction of the posterior midbrain, which will lead to vertical gaze palsy because you destroyed the trochlear nerve, which allows you to look up. Okay? Trochlear nerve, it controls the superior oblique, so it allows you to look down. So the vertical gaze palsy is an ability to look in a vertical type of fashion, and in this case, you are not able to look down. So that means vertical gaze palsy, which is happening due to the trochlear nerve compression. Also, pupillary light near dissociation. What does that mean? So basically what that means, when you bring a light, put it in someone's eyes, what he will do for you? He's going to, basically his eyes are going to constrict. That happens with the help of a cranial nerve number 3. And well, which brain does the cranial nerve number 3 come out from? Answer is midbrain. Okay, and lid retraction, why? Again, the oculomotor nerve is responsible for many muscles. One of them is levator muscle of the pelvifera, which is the eyelid. So if that is not working, you will have lid retraction. And we have this convergence retraction nystagmus. This is actually quite cool to take a look at. I will show you what you need to understand. What is nystagmus? It's a vibratory movement of the pupil. So I just want to show it to you guys. Hope I can find a good one. Okay, so look. Now all normal. Okay, come on, start by. Okay, that's what we are looking for. Look at this eye. See? Shaking. The best way to induce a nystagmus is to keep the patient moving his eyes. They get tired and the nystagmus starts. See? Just shaking. That's nystagmus, guys. As a GB, if you see nystagmus, send it to the doctor. We'll give you a general rule. If the nystagmus is horizontal, it's a problem. But if it's vertical, it's a big problem. Why? Because vertical one most likely is associated with brain symptoms. Horizontal nystagmus is most likely associated with ear causes. Okay, so he's trying to do this convergence retraction type of thing. I cannot say that he has a really severe form of nystagmus in that case. The previous one, yes. Okay, so the next thing is reticular activating system in the midbrain. So this is actually highly associated with the pyramidium pontine reticular formation. So actually it comes under it, the reticular activating syndrome. The reticular formation, or the reticular, the pyramidium pontine reticular formation is composed of almost 100 nucleus. This 100 nucleus is dispersed? Yes, dispersed all over the brainstem, not only the bones. But they have many structures inside of them. If you take a look at the reticular formation structures, you will see how big it is. Well, it's actually small, but they just like have 100 nucleus. That's the thing. So here they draw it as one structure. This is not true. It has many small nuclei. Okay, so see these lines? The lines are the reticular formation that are composed of almost 100 nucleus. Somebody wrote that. I think it's true because it makes sense. Okay, so you can see so many nuclei are going to be in it. And one of these many nuclei, we spoke about it already. It was the reticular activating system in the midbrain only. And yeah, destruction of it will lead to the coma, as we said, because it's responsible for making you up, destroy it, you go to sleep. Cerebral hemisphere destruction can lead to an intention tremor. We'll speak about what does positional intention tremor mean. Limb ataxia and loss of balance. Of course, we are speaking not cerebral, cerebellar. So that is the cerebellum stuff. Yes, that's why we have the intention tremor. Guys, intention tremor is like tell the patient to touch your finger and then touch his nose. He will not be able to touch his nose. His finger will go all over the place, right? Because his proprioception is messed up. He has loss of balance as well because of damage of the cerebellum. The problem will be ipsilateral, okay? And he will fall on his lesion, basically falls towards the lesion. So if it was in the hemisphere of the cerebellum, it's going to affect the extremities. But if it was in the vermis of the cerebellum, it's going to affect the trunk. So again, a trunk, vermis, hemisphere, the limbs. So in the trunk, it's going to be a white base, a drunken sailor gait. It's like opening his leg and moving, like he has some type of irritation between his legs. And also nystagmus. Vermis is centrally located. It affects the central body, which is the trunk. Degeneration is associated with chronic alcohol use. Remember, alcohol is directly poisonous for the Purkinje cells of the cerebellum. The red nucleus of the midbrain destruction can actually is quite interesting. they like to utilize the red nucleus of the midbrain as a mark, like as a ground mark. What do I mean by a ground mark? Well, because this is your midbrain. Inside of your midbrain, you do, okay, good enough. You have this red nucleus. So they say the lesion is above it or the lesion is under it, okay? The lesion is above the, basically the red nucleus or under the red nucleus. If it was, okay, let me see, no. Okay, good. You can see the red nucleus here. If the lesion is under it or above it. So they say, if the lesion was above it, the patient will have a decorticate type of posture. If it was under it, it will be decerebrate. Just logically, guys, which one is going to be worse? The one affecting the midbrain or the one affecting the brain? I'm sorry, the one affecting the brainstem or the one affecting the brain? Which one is going to be worse for the patient? Well, logically, it's going to be the one that affects the place that has the circulation center, the breathing center, and all of that, which is the brainstem. You're like, wait a second, are you trying to tell me that from the posture of the patient, I can tell if the lesion is under the midbrain, or over the midbrain, and according to that, I can expect the prognosis of the patient? Exactly, that's what I'm saying. So if it was decorticate, it is above the brainstem. Better prognosis. Notice all of his muscles are flexing towards his body. Decerebrate, so they say decorticate, the hands go to his core, which is his heart. Decerebrate is something affecting the brainstem. So it's going to extend his arms. Extension of the arms is a really bad sign of this disease. So they write here, decorticate, he will have a flexor posturing. Lesion will be above the red nucleus, presents with a flexion of the upper extremity and extension of the lower extremity. If you were me, just worry about the upper extremity, okay? So the decerebrate lesion at below the red nucleus, which means directly affect the brainstem, much more lethal. Presents with extension of the upper and the lower extremity. As you can see, the lower extremity don't matter much. It's always extended, but the upper extremity does matter. Decorticate, hands to your core, hands to your heart. So flexion. Decerebrate, extension of both. Worse prognosis with the decerebrate posture. In the decorticate posture, your hands are near your heart, your core. Okay? Good. So we are done with the first horrible page that contains a lot of stuff. Now it becomes more fun, I have to say. So I will see you guys in 10 minutes to start the normal material. See you in 10. Okay, everyone, welcome back. So yeah, recording, good. So let's start with the next thing. The next thing is speaking about like one of the most common causes of death after CVS after cardiovascular infarctions. You guys, every single one of you is going to see a stroke. Like, not you getting the stroke, your patient. It's really common to see somebody with a stroke. Why? Well, basically, to start with, our lifestyle is not the best. We do eat a lot of fat. Some of us smoke. Some of us do all of the risk factor of atherosclerotic disease. Wait a second, so stroke is caused by atherosclerosis? Well, not only, but yes, it is caused by it. So let's try to understand what is a stroke, how is it happening, how to treat it, how to diagnose it, and what is the prognosis of it, and what does it depend on. So, ischemic stroke, ischemic brain diseases, and a stroke. It's an irreversible neuronal injury that begins after 5 minutes of hypoxia. Why it's irreversible? Because neuronal cells are which type of cells? Permanent cells, yes. So they are permanent cells. They do not divide, they do not proliferate, that's it. You have them, and if they die, they are gone. The damage for them starts after 5 minutes. So if you see somebody who fainted on the ground and his his heart is stopped, what is the first thing to do? No, you check your surrounding. Be careful about that question. First thing to check, this is basic life support common question. Oh, somebody fell in front of you. What is the first thing to do? Somebody says, check the pulse. Somebody says, initiate CPR. The correct answer is to check your surrounding to make sure you are safe. Okay, it's a tricky question. I hate this type of question, but what can we do? So, yeah, after that, you start obviously the CPR to keep the perfusion to the brain, and you do give the patient mouth-to-mouth breathing. Remember the rule, 2 breaths per mouth, 30 compression on the chest. Your compression should be strong. You need to be able to push 2 inches inside of his chest. Most vulnerable area to the ischemia include the hippocampus, and if you destroy that, what will happen to the patient? Inability to make new memories, absolutely. So new cortex as well, and the cerebellum, especially the Purkinje cells. Remember, the Purkinje cells in the cerebellum are also really sensitive for one more substance, which is alcohol. Alcohol. They are really sensitive to alcohol. Watershed area can also be affected. If you remember, these were the area between the ACA and the MCA, and between the MCA and the BCA. And also the hippocampus is considered to be a watershed area. Imaging, stroke imaging. So, okay, we have a patient with a stroke. First of all, I want you to know that we have 2 types of a stroke. The first type of a stroke is an ischemic stroke, in which you have a blood vessels going to the brain that is getting occluded somehow, doesn't matter how. The other type of a stroke is you have a blood vessel that is going to the brain, but now it has burst. So it's fleeing blood to the outside, creating hemorrhage in the brain. So this is hemorrhagic stroke and this is ischemic stroke. Both of them suck. But the idea is which one you can manage how. The symptoms between them are a bit similar but not identical. For example, an ischemic stroke, the symptoms will be progressive. In hemorrhagic stroke, the symptoms are going to be sudden. If we speak about hemorrhagic stroke, you are more likely to feel nausea and vomiting. Ischemic stroke, less likely to feel that. But in general, if you have focal neurological symptoms in any patient, the first thing to do is a non-contrast CT scan of his head. Why? You just want to make sure he does not have blood. So, I just want to show you the next thing is a hemorrhagic stroke. So we don't use the contrast because the contrast can make, can give you false result, basically. You don't want that. So this is a hemorrhagic stroke. Remember, always on a CT, the hemorrhage looks white. So yeah, that's hemorrhagic stroke. That's hemorrhagic stroke. That's hemorrhagic stroke. This is a hemorrhagic stroke, but this one really sucks because it's intraventricular. Okay, so if it's intraventricular, high mortality, basically. But wait a second, what is this? Well, this is an ischemic stroke. So always ischemic stroke look like this? The answer is absolutely not. If you do a CT scan 1 hour after the stroke, if it was ischemic, you will see absolutely nothing. Okay? This is the edema that occurs after the stroke in 1 to 2 days. Okay? So basically what I want you to know, ischemic stroke, initially you will see nothing. Hemorrhagic stroke, you will be able to see the blood. Ischemic stroke can have edema and something appearing like this, but this will happen 1 or 2 days later. Okay? So you can see here hemorrhagic versus ischemic stroke. Hemorrhagic is white, the blood is white, and ischemic, you can see here the edema of the brain. That's it, nothing more than that. Okay, good. So you can see even the picture I just sent, this is an MCA stroke in both cases. One is hemorrhagic, one is ischemic. Okay, so you're doing the non-contrast CT scan to exclude hemorrhage. Why? Because you might want to give the TBA. What is TBA? It's a magical drug, guys. So this medication basically help to dissolve the clot. Okay, it helps to dissolve the clot if it exists. However, it is basically like an anti-thrombosis type of thing, a thrombolytic. Would you like to give it to somebody who has hemorrhage in his brain? No, not a smart idea. Don't. No, hemorrhage in brain. No, no, no. Don't give it in somebody who has hemorrhage in his brain. Only ischemic. So what about somebody who has diverticulosis? Would you like to prescribe TBA, which is a thrombolytic, who will make you bleed as hell, in somebody who has diverticulosis, which you bleed already? No? Okay, what about somebody who had surgery today, early today, with a big wound? No. What about somebody who is having, what else can bleed? Somebody with hemophilia. Will you give it to somebody with hemophilia? Nope, nope. Okay, good. So it has an exclusion criteria. Basically, a lot of things you will not give this medication in, because if you give it, you can cause more harm than good. So CT detects the ischemic changes in 6 to 24 hours. That means most likely when you check the patient, it will be early on, before 6 hours. So on the CT, an ischemic stroke, you will see nothing. You can do diffuse weighted MRI that can detect ischemia within 3 to 30 minutes. This is a really expensive study. Not a lot of hospitals do it. And it's not necessary. So diffusion weighted. And one more thing. If you do it in a hospital, your attendee will hate you. Okay? So please don't. Basically, it's a fancy test that tell you exactly the distribution of the blood inside of your brain. So if you see that one area has less distribution of a blood, it can tell you basically, okay, exactly where is the blood going inside of your brain. Okay. So by taking a look at the image, some areas look bluish and some areas look red. Blue area are not perfused, red areas are well perfused. So the patient here has an MCA infarction at this lobe, okay? Because at this side there is normal perfusion, at this side the perfusion is lost. So nobody do that, nobody like that, don't do that, don't make your attendee hate you. Okay, it's really expensive by the way. So everybody do CT. Histological feature are different things that can occur after the infarction, ischemic infarction basically. So if we say that this is a brain tissue and this is a blood vessel going to it, something will happen here that we'll discuss here, led to occlusion of the vessel. So what is going to happen to the tissue? Initially, the first thing to see is an eosinophilic cytoplasm. Why? Because of the destruction of the cell. Remember in apoptosis, when we used to say, oh, the cells become pinkish, right? So you will have an eosinophilic cytoplasm plus a pycnotic nuclei. Pycnotic nuclei, basically the nucleus is going to condense, preparing for the death. So let's take a look at that. In medicine, they use the term red neurons, red neurons. So that's the most initial thing to see after 12 hours. The next thing you are able to see a little bit after that is going to be the necrosis and the neutrophil infiltration in the brain. So yeah, a lot of neutrophil in the brain. It's similar to the MI if you remember. It's 1 to 3 days, and from 3 to 5 days, it's macrophages. Macrophages of the brain, we call it microglial cells. Exactly like the heart. And 1 to 3 days, neutrophil. 3 to 5 days, macrophages. Okay, 1 to 2 weeks have passed. Well, if it was the heart, you will have connective tissue deposition and, fibrosis. This is not true for the brain. Instead of fibrosis, you will have reactive gliosis. So, reactive gliosis is mediated by the astrocyte plus the patient is going to have vascular proliferation in the area, and this reactive gliosis actually looking quite cool. So I hope I can find a picture of it. Reactive gliosis. Okay, come on. Okay, that's good. Okay, basically the astrocyte will gather together, and make this thing. This is the gliosis, okay? And you can see between them all of this garbage around it. This is the gliosis, guys. But basically you can see the collection of the astrocyte around each other. The astrocyte are basically the supportive cells, okay? And that they keep everything together, and they help to reconnect the destruction and the connection. So initially, you can see here all of this astrocyte, and you can see around them is the gliosis. So you need to know what it is. You don't have to know exactly how it looks like. I just want to see a gross image of it. Okay, this one has a... Oh, guys, by the way, which type of necrosis occurs in the brain? Is it coagulative or liquefactive? Liquefactive, absolutely. Here it is. You can see it here, you can see it here. Mostly here. Okay. Which structure is located exactly right here, guys? Let me mark it for you. Which structure is located here? If they show you in the USMLE. It is the hippocampus and the amygdala. This structure is the corpus callosum. This is the lateral ventricle. This is the third ventricle. Okay? And I know it does not look the perfect thing for you guys, but this is the lentiform nucleus. Okay? So yeah, this is the lentiform nucleus. And this is the caudate nucleus. Okay, so let's take a look here. Eventually you will get a scar of your brain. Remember, it's a liquefactive type of necrosis. Ischemic stroke, you can see a left MCA infarction at that area. It's an acute blockage of the vessel, which will disrupt the blood flow and lead to subsequent ischemia of the brain. Infarction will occur, and eventually a liquefactive type of necrosis. Remember, the tissues that used to have liquefactive necrosis are, the brain is one. The second one was the pancreas. Pancreas had two types of necrosis. It has the liquefactive, and it had the fat necrosis as well. And the third one, it was an abscess. The abscess also can have a liquefactive necrosis. So there is three causes and three types of ischemia that can cause the ischemia. The first one is the thrombotic. It's due to a clot forming directly at the site of infarction. Okay, so let's take a look at that. So it's a clot that can form right here. Thrombotic, due to a clot forming directly at the site of infarction, most commonly the MCA on the left side, right? Usually over a ruptured atherosclerotic plaque. Let's try to understand this. So you had atherosclerosis initially here, and this is the brain here basically. Let's make it. Okay. And yeah, life was going, and this was slowly enlarging. Doesn't really matter. One day, this cells that are located here, the endothelial cells, just got ruptured. So the subendothelial collagen got exposed, and really quick all of this platelet has accumulated here and infarction, right? So this is the first one, a thrombotic infarction due to a direct clot forming at the site of the infarction. The second one is the emboli. An emboli like the people with arrhythmias. So emboli from another part of the body that can obstruct the vessel. And the symptoms occurs much more faster. It can affect multiple vascular territory at the same time. It causes include atrial fibrillation. In case of atrial fibrillation, the left atrium is not contracting, which will lead to it to start forming what? Thrombi. And the thrombi will be forming inside of the appendages of the left atrium that eventually are going to exit the left atrium to go inside of the systemic circulation and to the brain. Because of that, it can lead to multiple, strokes at different locations, depending on the size of the emboli. Carotid artery stenosis can lead to that as well. That's why we always check the carotid artery size by Doppler examination and the blood flow through them after the MI, and you do an ECG. Guys, everybody who gets an MI, you must do an ECG for him immediately. Even before you do the CT scan, you do the ECG. Just to make sure he does not have an AFib. Okay, also, DVTs can lead to that. You're like, wait a second, that does not make sense. DVTs are in the leg, right? And it's deep venous thrombosis. So if a emboli form inside of the leg and it goes up, it will go back to which chamber of the heart? The right heart. So logically, it will go to the lung, not to the brain. So only in cases when there is connection between the right and the left heart, you will get a stroke from a DVT. So only in case of foramen ovale, you will get a paradoxical emboli that actually can go to the brain. Infective endocarditis, for example, due to Staph aureus, can help in the formation of a bulky vegetation that can actually lead to a septic emboli that can travel to the brain and lead to stroke. Hypoxia, generalized hypoxia, due to hypoperfusion or hypoxemia. Common during cardiovascular surgery in which you lose plenty of water. So, and it will affect most likely the watershed area, which include the hippocampus, the area between the ACA and the MCA, and the area between the MCA and the BCA. The treatment is with TBA. Guys, I had a personal family member who had this, and they did this for him, and this saved his life, basically. So, I want to teach you exactly how to deal with it. The patient comes to you with focal neurological symptoms. Cannot move a hand, cannot speak. Tell him, what's up, so what happened with you? And he's like, what's up with him? Why he cannot speak? Why do you think, guys? I mean, he understands you, but he cannot respond to you. You are telling him what happened, and he's like, what's up? What's wrong with him, guys? You tell me. You tell him to sign up the paperwork, he cannot write, he cannot use his right hand. He has a stroke. To which area? He cannot, he's frustrated while speaking. So to which area the stroke? It is Broca area. Because if he had Wernicke area infarction, he will be fluent, but he will not make sense. He will be telling you 2 cats and bottle of water and powder. And there was a lot of chickens in the microwave. And basically the book turned into a monster. He will make no sense. That's Wernicke. Broca, he's frustrated. Broca frustrated, Wernicke fluent but make no sense. Okay, anyway, you do the CT, you make sure he does not have hemorrhage. After that, you start the TBA. You give 0.9 milligrams for each kilogram of his body weight. Okay, and after that, you do, so if he was, for example, 100 kilograms, you have to give 90 milligrams, okay? That's how it goes. So the TBA, you give it, but only in this window. What do I mean by that? Until 3 hours, until 3 to 4.5 hours, you can give it. If it was after that, too late. You are like, okay, but what if, like, he woke up in the morning, okay, and he discovered that he has symptoms? Oops. Can you tell exactly when did it start? No. So, no, you don't give. That's the thing. You don't give. You don't take the chance. Some doctors do give it, but the protocol tell you not to give. Okay? So just keep that in mind. So, 3 until 4.5 hours of onset and no hemorrhage and no risk of hemorrhage. No diverticulosis, no recent surgery, nothing like that. And or a thrombectomy. Okay, so if it was, for example, a huge infarction of the internal carotid artery, you can just pull it out. Reduce risk of medical, reduce risk with medical therapy like aspirin or clopidogrel. Even if he had a hemorrhagic stroke, aspirin will not be that horrible. Okay, so still, even if he had hemorrhagic stroke, take 425 milligrams of aspirin, the one big tablet, crush it, put it inside of his mouth. Do not give it to him as a whole. Remember, this patient in a stroke, he cannot swallow normally, guys. He cannot swallow normally. Just crush it, make it like a powder, and spray it inside of his mouth. Optimum control of blood pressure, because this is super horrible. That's what kills them and can lead to herniation. But when you reduce their blood pressure, make sure you do not reduce the blood pressure more than 10 millimeters of mercury per hour, okay? You're only allowed to do that, 10 millimeters of mercury per hour, not more than that. After that, blood sugar, lipids, and smoking cessation, and treat the condition that increases the risk. Atrial fibrillation, rate control, rhythm control, and after that, you do the cardioversion, get the man back on track. Carotid artery stenosis, if you need a stent, put one. TIA, what is TIA? This is really common, guys. Somebody has focal neurological symptoms, basically an infarction, like it looks like a stroke, but it's not a stroke. It looks like a stroke with all of the symptoms, and then it disappears. What the hell? What happened? Well, it's a brief reversible episode of focal neurological dysfunction without acute infarction. So the patient will have a negative MRI, with the majority resolving in less than 15 minutes. So in cases of ischemia, it can be due to an embolus or a small vessel stenosis. So it's just an embolus occluding the vessel or a small vessel stenosis. And yeah, it may present with amenorrhosis fugax, in which the patient will be like normal, and suddenly from his internal carotid artery, one piece of emboli will pass into his ophthalmic artery that eventually goes to his eyeball. So that will make him lose his vision quickly, and then it will come back. So that's amenorrhosis fugax, okay? TBA or TIA? No, I'm saying TIA, which is a transient ischemic attack. It's basically the emboli. Maybe I said it wrong. I'm sorry. So the emboli will go into the retinal artery from the carotid artery, and then it can lead to symptoms that will disappear quickly because the emboli is so small, it dissolves so quick. Okay? So, but it's recurrent. If he had it once, he will have it again. May present with amenorrhosis fugax due to retinal artery emboli from the carotid artery disease. This patient might be a candidate to, I cannot say this word, it's kind of a mouthful for me, but it's basically a carotidoenterectomy. Carotidoenterectomy, in which basically I cannot find it. Carotid enterectomy, in which we remove his carotid artery sinus in that lesion, and you can remove with it the thrombi that exists inside of it. So he cannot have a thrombosis in the future. But to do that, he need to have so many TIAs. Okay, neonatal intravascular hemorrhage. This is interesting. It's common in premature babies. Premature babies are the babies who are born less than 32 weeks of gestation. Bleeding into the ventricles, show blood in the intraventricular spaces on an ultrasound. You're like, wait a second, you are lying. We cannot do an ultrasound on the head. That's true. In us, you cannot. But can we do it on a baby, on a newborn? Absolutely yes, because they have a fontanelle, right? They have an opening on their head. So it's possible to do that. You will be able to see all of the structure of the brains. It required a person who is really good with ultrasound to detect all of the structures, but that will not be a problem. You will have somebody to do that, but the main thing is to be able to know that actually you can do that. So in case of intraventricular hemorrhage, it's possible to check for it. Increased risk in a premature and low birth weight infants. It originates from the germinal matrix. What is the germinal matrix? Well, inside of your lateral ventricles, during fetal life period, there was something here called germinal matrix, which is a plexus, okay? It's a collection of blood vessels, okay, that are located here. So normally, when we become after 32 weeks of gestation, they simply disappear. But if the patient is born before that, they will stay. So it originated from the germinal matrix, which is a highly vascularized layer within the subventricular zone, due to a reduced glial fiber support and impaired autoregulation of blood pressure in a premature infant. These blood vessels will just burst. When they burst, the patient is going to have blood inside of his ventricles, right? So it can present with altered level of consciousness in the baby, bulging fontanelle, you know, this opening in his head because of increased intracranial pressure, basically, right? But the baby will have hypotension, seizure, and coma because of the bleeding, basically, inside of his brain. The prognosis is really bad. Even in us adult, anytime the blood inside of the ventricle of the brain, the chance of death is 90%. Subdural hematoma, epidural hematoma, subarachnoid hematoma, the death itself is like 10 to 20%. But in intraventricular hematoma is 90% or even more. Okay? Okay, speaking about hematoma and hemorrhages of the brain. Damn it, there is a lot of ways we can kill a patient. Let's start with the first one, epidural hematoma. Some people came to a person and they were like, oh, give me your money. And he refused to give them the money. They took a baseball bat and hit him on his head and took the money and ran away. So, what should you do with this patient? Call the police. I'm kidding. So the patient, after getting hit, he might lose consciousness. But after losing the consciousness, he will be back up. He's back up. His friend bring him to the hospital. And he's like, oh, my head hurts, but I feel fine now. What you should do? Let him go home and have something to eat? Or hospitalize him? He just got a hit, you know? It's nothing serious, just a hit. He told you like just a hit, it's nothing serious. Like, I got hit, but I don't feel like it's bad. I have a little bit of headache, but that's probably because of the hit, nothing serious. Yeah, you admit him, not an MRI, that takes time. Remember guys, MRI takes around like 40 minutes to do, so that's a lot of time. You have to do a CT scan. Also, MRI is good for inflammatory condition. CT scan is good for bleeding condition. So yeah, you must do a CT scan. If you don't, his family will love you, because when he dies, you owe them a lot of money, okay? And you don't want your patient to die, so do the CT scan. When you do the CT scan, if it's clean, send him, like, keep him for observation for 4 hours, and after that you send him home. But if it is abnormal and you see something like this, say, bingo. Why? He has a rupture of the middle meningeal artery. You need to know the name of the vessels. For the epidural, is middle meningeal artery. For the subdural, is the bridging vein. For the subarachnoid, is the actual brain vessels, the aneurysms. So you must know the names of the vessels, okay? So in epidural hematoma, it's the middle meningeal artery, which is a branch of the maxillary artery that went through the foramen spinosum, if you remember. So that was the maxillary artery gave a branch that went through foramen spinosum, and it became the middle meningeal artery. Often secondary to a skull fracture. So there is an area in your head called the pterion. It is the thinnest area of your skull. Thus, it's the most likely to be penetrated or, you know, basically destruct. Okay, I have this agraphia. I have a problem with writing, so. Okay, so this is a pterion. It's basically located just right here. They even call it like near the squamous suture, which basically means the thin area, okay? So this is the thinnest area of your head. Super thin. Just, it's millimeters in thickness. Super thin, that means you can destroy it super easily. Okay, so it might present with a transient loss of consciousness and then recovery. We call it a lucid interval. Rapid deterioration due to hematoma expansion after that. So the patient, remember the story. He gets hit, he lost consciousness for moments, then he wakes up. I feel fine, nothing bad with me. My friend took me to the hospital. The doctor said, oh, it will be nothing. Send me home, deterioration, the patient dies. Lawsuit, you go to jail. You don't want that. So, next time, he gets hit, he loses consciousness. He wakes up, he says, I'm fine. He come to the hospital, you hospitalize him, you do a CT scan, you see this, you are like, okay, you need a brain surgery. You do the brain surgery and the patient is perfect, okay? That's a lucid interval. A scalp hematoma you can see it here. It's outside of the skull, okay? And rapid intracranial expansion, which is inside of the skull. So if you can see it, I don't know if you can see it, there is something here, right? And there is one more here. So one outside of the skull and one inside of the skull. It does not always happen like this. It could be only the one inside of the skull. And you can see, in this case, the actual fracture of the skull, actually. It's right here in the pterion. So, rapid intracranial expansion under systemic arterial pressure. Well, it's from the maxillary artery, which will lead basically to more blood to be pumped inside of your skull, which can lead to a transtinctorial herniation and CNS3 palsy. So what is tinctorium? Tinctorium is one of two main membranes, tinctorium, that exist inside of your brain. We have two main ones. The first one, so yeah, you can see this thing? We call it falx cerebri, this guy. It's between the two hemispheres, basically, just a membrane. And yeah, this is it. Falx cerebri and falx cerebelli. And this is the tinctorium down here. So if you increase the pressure inside of the brain so much, a portion of the brain is going to bulge down. We call that herniation. Herniation, again, the death is highly likely because they compress the brain down. When it's going to compress down, the first structure to be pushed is actually the third cranial nerve. The pushing of the third cranial nerve will lead to a third cranial nerve palsy. So you can see how this is the herniation is occurring, which is bulging down of the brain structure, and this basically leading to compression of the cranial nerve number 3, the first cranial nerve to be involved. So you can see the tinctorium here, and this is just herniation under the tinctorium. It can be subfalcine type of under the falx cerebri, so it can be subfalcine as well, herniation, depending on where is the bleeding and how is the pushing occurring. Okay, so this is a transtinctorial and this is ankle. Okay, so CT scan will show a biconvex lentiform, looks like a lens, guys. Hyperdense blood collection does not cross the suture line. If it does cross the suture line, this is subdural, does not epidural. So this does not. It's only in one side. It's not going here. It's not going there. That's epidural. The second one, however, the subdural hematoma, it's a rupture of the bridging vein. Bridging vein? Well, yeah, bridging vein are the vein located from under the dura mater. They connect the dura mater through until the arachnoid. Okay, so they go something like this. Rupture of the bridging vein, it can be acute due to the trauma, high energy impact, for example, a car accident, and it can lead to a hyperdense on CT again, which is basically, as you can see here, in an acute state it will be white, but if it was chronic, it will basically thrombose after that and becomes black. So initially it's white and eventually it becomes black. Okay, so it's associated with the trauma, cerebral atrophy, elderly people, and chronic alcohol use. Let me explain why these causes are mentioned here. A trauma makes sense. That does not require explanation. Cerebral atrophy, like Alzheimer's disease, however, does require explanation. If this is your skull and this is your brain, and the bridging vein are going like this, let's see. Now, let's make your brain much more smaller, right? Because of Alzheimer. So now it's like this. What will happen to the bridging vein? They will become stretched, correct? If your bridging vein is more stretched, of course this is a schematic, your brain will not become this small. But when the bridging vein are so stretched, initially they were like this, but now they are super stretched. If you get a minor trauma, like a really heavy shaking from a car accident, for example, what will happen to the bridging vein? They will rupture, right? So I repeat, the brain was big. So this is the skull, and this is the brain inside of it. The bridging vein were like this. They had the twitches, no problem. Now the brain becomes small. So the bridging vein are stretched, right? So now, if you get in a car accident, for example, they are going to rupture. Well, what can lead to the brain to become small? Cerebral atrophy from Alzheimer's disease or other neurodegenerative disorder like Parkinson's disease. All people can have this as well. Okay, so what about, and also chronic alcohol use, because that can lead to the destruction of the structure of the vessels. So they will have a hypodense on the CT because it has been occurring for years. Oh, okay, nice, they mention it. Also, it's in a shaken baby syndrome. What is shaken baby syndrome? It's a form of child abuse, okay? So shaken baby syndrome is a form of child abuse. If you see something like that, you must report it. You are obligated to report it. If you don't, you will be in a big trouble. Basically, the parents have this child and the child wants to stop crying, okay? So they hold him and they start shaking him. I'm not saying that shake him mildly. No. They shake him in a really bad way. Because of this huge shaking, his bridging vein gets destroyed. And that will lead to subdural hematoma. When they bring him to your emergency department, they will tell you that the story will be about a 2-month-old baby. Mommy bring him to the hospital and she tells you, oh, my poor child, he crawled out of his bed and he just dropped to the ground and I'm bringing him to you. And he has this, and you check him, he has subdural hematoma. There is something wrong with the story. What is it? Come on, Sherlock Holmes. I repeat, mother bring the baby to you. Why do you think it's abuse? Why you thought it's abuse? You are right, but why do you think it's abuse? I repeat the story. A mother bring her 2-month-old child, and she tells you that, well, it can be from trauma. She tells you that he was in the bed, but he rolled over and got out, like basically just rolled herself over and fell from the bed and hit his head, and she's crying vigorously because her child did that. Exactly, a 2-month-old cannot move. If you put him in his back, he cannot move anywhere. Children start to be able to move a little bit after 4 to 5 months of life, not 2 months. So the story does not fit the milestones of the baby, which means she's lying. So she's lying, it's a subdural hematoma, you see that, you report to Child Protective Services. You are obligated to do that. Don't think that they will take her baby away from her. They won't. They will just regulate that the baby will stay safe when they bring him back to her, okay? Which is a good thing. So, rupture of the bridging vein, we spoke about all of this. Shaken baby syndrome. Predisposing factor is brain atrophy and the trauma. A crescent shape hemorrhage. Crescent shape, yes, it's like the moon, guys. See, it's crossing the sutures. Crosses the suture and can cause a midline shift. Why? Because, pressure at one location, if you make the midline like this, oh, there's a shift to the other side, right? Okay. Finding of acute and chronic are seen here. So this is acute, it will be white, chronic will be black because the blood gets thrombosed. Subarachnoid hemorrhage. Do you remember what exists inside of our subarachnoid space? CSF. Good. So bleeding due to a trauma. And you can see that the blood is inside of the crescent of the brain, which means the areas between the lobes, okay? Bleeding due to a trauma or rupture of an aneurysm, such as a saccular aneurysm. Saccular aneurysm, what is that? Well, let's take a look at a saccular aneurysm. Saccular aneurysm can occur because of hypertension, but most likely it can be, most likely due to hypertension, but also it can be in connective tissue disease. This is a form of saccular aneurysm, as you can see here. In medicine, anytime they show you an aneurysm and they ask you this patient most likely will have what? You have to say rupture, okay? So they write saccular aneurysm or an AV malformation. Don't forget about Osler-Weber-Randy syndrome that have the atriovenous malformation. Rapid time course, so it will happen super quickly and the patient will be like, doctor, I have the worst headache of my life. It's really, really bad, okay? And when you do a lumbar puncture on them, you will be able to see xanthochromia, which means basically that you know, the CSF that you got out will be yellowish or bloody. If it's bloody, all of the 4 tubes will have a blood in them. But if it was xanthochromia, that means that the bleeding happened a while ago and the RBCs has converted into bilirubin. That's why they are yellow, xanthochromic. Okay, vasospasm can occur after the blood got out from the brain, like from the vessels, and that's serious. Why? Because the vasospasm can lead to ischemic infarction after the hemorrhagic infarction. Wow. So vasospasm can occur due to the blood breakdown or rebleed 3 to 10 days after the hemorrhage, basically leading to an ischemic infarction after that. To prevent that, after the ischemic infarction, after the hemorrhagic infarction of the brain, you can give nimodipine. Remember Nemo? Nemo had no brain. Nemo the fish, right? Nemo the fish, well, Nemo, he has no brain, right? So we use it for the brain. Nimodipine is a calcium channel blocker that reduces the vasospasm and it prevents a complication such as basically ischemia. Well, you know, ischemic infarction. Increased risk of developing communicating or a non-obstructive hydrocephalus. Why? Because the blood is irritating the the arachnoid granulation. Arachnoid granulation normally absorb the CSF and send it to the venous system. So the arachnoid granulation can be basically having this fibrosis of them. That means they will be unable to have CSF passing through them, which can lead to an obstructive hydrocephalus. Intraparenchymal hemorrhage is the last type. Okay, just really quick. This have a lens shape. This has a this crescent shape. This is inside of the cisterine of the brain, like inside of the structure of the brain, and it can go into the CSF. But this is intraparenchymal hemorrhage. This is going to be inside of the parenchyma itself. I mean, not in the sutures, but inside of the brain, pushing the tissue around it. It's not near the skull. No, it's inside of the tissue. Okay, so that's intraparenchymal. This one sucks. Most commonly caused by systemic hypertension, also seen with an amyloid angiopathy. But I want you to know that it's not due to a big vessel breaking down. The big vessel, it will lead to subarachnoid hemorrhage. It's a small vessel type of thing. So yeah, systemic hypertension, also seen with amyloid angiopathy. It can be leading to a recurrent lobar hemorrhage, hemorrhagic stroke in old people, and vascular malformation, vasculitis, and neoplasias. Basically, so many symptoms that involve a lot of blood vessels in the area. Maybe secondary to reperfusion injury in ischemic stroke. So let's try to understand what is happening exactly in this case. The most common cause, hypertension. So there is something known as the Charcot-Bouchard aneurysm. They are minor aneurysms. Bouchard aneurysm. They are minor aneurysms that are created in this artery, the lenticulostriate artery. Yes. So this is the MCA, right? And it has this lenticulostriate artery coming out of it. And this is the Charcot-Bouchard aneurysm created because of the hypertension. I repeat, patient has hypertension, which lead to Charcot-Bouchard aneurysm, and thus, in the lenticulostriate artery, which is a branch of MCA, and that can rupture, which lead to intraparenchymal hemorrhage, affecting mainly the basal ganglia, right? You can see it's affecting mainly the basal ganglia. Okay, good. Most often occurs in the putamen of the basal ganglia, lenticulostriate vessels. Okay, followed by the thalamus, the bones, and the cerebellum eventually. So yeah, most commonly it likes to affect the basal ganglia. I have seen this in one read exam, guys. So it can affect the cerebellum. They literally showed an infarction of the cerebellum here. And they said which type of, well, infarction was it? All of them were there. It was super easy. It was intraparenchymal hemorrhage. Most common cause is hypertension. Okay guys, let's have a little break for 10 minutes, come back, speak about different arteries involvement, and we'll stop it here. So see you guys in 10 minutes. Hello everybody, welcome back. So let's continue this. So the last thing for today is to speak about some actual arteries and what is their effects. Remember, we have two circulation in our brain. We have anterior circulation and we have posterior circulation. For now, I will only explain the anterior circulation because the posterior circulation requests me to draw a diagram that I will not do now because you will forget it. In the anterior circulation, remember, it's your internal carotid artery becoming your MCA and ACA, right? Internal carotid artery becoming the MCA and the ACA. Okay. The anterior cerebral artery or ACA, it can lead to motor and sensory cortices affection of the lower limbs. Why? Because it affects the homunculus at the medial portion of the brain. If this is your brain, remember, your leg is here, your arm is here, your face is here, right? So, the anterior cerebral artery, it just goes between the two hemispheres and rolls over, which basically means that it will involve the lower limb. The patient will have a contralateral paralysis and sensory loss in the lower limbs, and he might have urinary incontinence as well, because lower extremities in general. MCA infarction, which is much more common, it depends if it was left-sided or right-sided. The most common one to be left-sided. The patient is going to develop motor and sensory cortices affection at the upper limb and in the face. Let's take a look at that. So you can see how the MCA here in this case is involved. Okay, the temporal lobe contains the Wernicke area. The frontal lobe contains the Broca area. Both of them can be affected during MCA infarction, depending where is at which branch of the MCA is the infarction in. So, if it was the Wernicke area, the patient will have which type of aphasia? Is it fluent or non-fluent? In Wernicke area, Wernicke will be fluent, guys. Wernicke will be fluent. I told you, he will keep speaking, but he will make no sense. That means he's fluent. Broca area in the frontal lobe, he will be frustrated, right? So non-fluent. Broca, non-fluent. Wernicke, fluent. Broca, non-fluent. Wernicke, fluent. Contralateral paralysis and sensory loss, face and the upper limb affection. Aphasia in the dominant, usually the left hemisphere, and hemi-neglect if the lesion affects the non-dominant hemisphere. So again, the patient is going to have the following. Affection of the face and the upper limb. Why? Because if we draw the brain, the MCA supplies the outer portion here and this portion here, which is the arm and the face, right? In the same time, if you are involving the left hemisphere, you will have aphasia. Why? Because the place where the center of speech is located is on the left side. Hemi-neglect can occur in which like it happens this thing like I draw for you, half of the clock is drawn. That's hemi-neglect, or shaving half of the face. That's hemi-neglect. It's when the affection of the right MCA, okay, non-dominant one. Good. So Wernicke aphasia is associated with the right superior quadrant visual field defect due to temporal lobe involvement. Basically, we'll learn a little bit later that the optic field, optic nerve, makes the optic chiasm. From the optic chiasm, it goes to the superior colliculi in the midbrain. From the midbrain, it will make something called the radiation. So one will go through the temporal lobe and one will go through the parietal lobe. The one going to the parietal lobe will affect the inferior quadrant of the eye, okay? And the one going through temporal lobe will affect the superior portion of your eye, okay? Okay, we'll learn about this a little bit later, but basically if this is your visual field and the temporal lobe defect will occur, let's say it happened on the right side. So on the right side is going to lead to something like this, okay? Okay, so the next thing is lenticulostriate artery. Where did we see this before, guys? Where did we see this before? In which type of hemorrhagic stroke this was involved? Well, yes, the parenchymal one. So that supplies the striatum and the basal ganglia in addition to the internal capsule. So the patient will have a contralateral paralysis, absence of cortical sign, neglect, aphasia, and visual field defect. Nice. Can you see any pain and temperature problem? Or is it all motor? Yes, there is the visual stuff, but is there any pain or temperature? No. That's why we call it a pure motor stroke. A pure motor stroke because it affects the basal ganglia. This is lenticulostriate artery affection. Common location is at causing lacunar infarction. Lacuna means a lake. So it's a lake-like infarction in that area. It can be happening because of the Charcot-Bouchard aneurysm, or also it can happen due to microatheroma and hyaline arteriolosclerosis. Let me show you how a lacunar stroke look like. Lacunar stroke. Look, because of the destruction of so many small blood vessels in that area, the macrophage will eventually eat them up, right? So because the macrophage will eat them up, they will start to make small lakes. Okay, so this is the basal ganglia. Can you see 1 lake, 2 lake, 3 lake, 4 lake, 5 lake? So this is lacunar stroke. Here you go. Okay, good. Yes, secondary to unmanaged hypertension. Okay, we spoke about that. Okay, guys, so that's it for today. Tomorrow we'll keep going with neurology, finish up stroke, speak about seizure, headache, and movement disorders, and neurodegenerative diseases as well. So see you guys tomorrow at the same time.